Honourable Member from Charlottetown, Belvedere.
Thank you, Mr. Speaker, and it's a pleasure to rise today on such an important topic. I'm speaking about this because I've heard from numerous constituents from across the island who have raised this issue as the one that they are most concerned about, both during and following COVID. And they are concerned because they are not hearing us discuss it here in the House. A motion is a really important way and the best way for us to be able to raise something like this, because we can debate and discuss at length, we can table information and references, and we can call for action. I know we're all tired of COVID and we want to be done with it. But as we often hear, COVID isn't done with us. There are lots of Google scientists and Facebook epidemiologists out there, and none of us in this legislature are public health experts. But in the past 2 years, we've talked about COVID a lot. We've learned a lot, and one of the things we have learned above all else is to trust the science and understand that scientific discovery, conclusions, and recommendations are based on evidence. Over time, we gather more evidence, and the recommendations may change. So sometimes it is useful to talk about science that is decided, that has happened in the past, or that has been determined to be incontrovertibly true, to help us understand a new circumstance that is very difficult to grasp. So for this motion today, Mr. Speaker, I'm going to start by talking about chickenpox. It's highly contagious, it's itchy, it mainly affects children, though adults can rarely get it too. And we have been vaccinating for the virus that causes chickenpox. It's called varicella zoster virus. It's actually a form of herpes since 1995 in North America and since 2000 here in PEI. It's actually one of the recommended vaccines for public school here in PEI. So everybody's children will have been, if they're vaccinated, will have been vaccinated for varicella as one of their early and then secondary vaccinations. A quick check in the room, though, Mr. Speaker, would tell us that some of us in here have had chickenpox because we're older than the vaccine rollout. I'm one of those, Mr. Speaker, by quite a few decades. The Minister of Health the same. In fact, who's had chickenpox and remembers how itchy it was? Yeah. In fact, it was pretty normal when we were children to have chickenpox. I don't know about you, but in my street they had a chickenpox party, because then everybody could get sick at the same time, and they were done, and then you could go back to school, right? And that was normal, because chickenpox when you're a kid was felt to be not that serious. We know now that viruses, though, are sneaky. And in fact, that's actually a problem. It's a problem that connects to what I'm talking about today, Mr. Speaker, because why does it matter? Why do we need to talk about chickenpox? You have to have had chickenpox in order to develop shingles. If you haven't had chickenpox, you cannot get shingles. The virus infects your body, and it stays in your body, in your nerve endings, for the rest of your life. So I had chickenpox when I was 6. I had shingles for the first time when I was 42. I could have shingles at some point, at any point in the rest of my life. But it waits, and it lingers in the background, and then one day you'll get sick. You cannot, though, get it if you've never had chickenpox, and if you've been vaccinated, you can't get shingles either. It hides out dormant, and it is incredibly painful and uncomfortable. In fact, 30% of adults will develop shingles in their lifetime, and 10% could be left with long-term debilitating pain. Anything that weakens your immune system, including stress, Mr. Speaker, can be the trigger for shingles. But it's very common when you have a severe illness or surgery or cancer treatment or any of those more invasive treatments that you'll get shingles as a response. And it also occurs more commonly as a person ages. In fact, a significant increase after the age of 50. And as a result, we now have the recommendation that people 60 years and older should be vaccinated for shingles with Shingrix here in PEI, and we're offering it for 65 and older. And they should get that vaccine whether or not they can remember. And I know a lot of people might not even remember if they had, but we are recommending that you get it regardless. So why are we making such a big deal about getting a vaccine, Mr. Speaker, for something which is, sounds terribly painful, but only affecting a certain number of people? It's not just nasty, though. And we don't want to just have that vaccine so that we can avoid that pain. People who develop shingles have a 60% higher risk of a heart attack and 35% higher risk of stroke. These risks are so significant that we are prepared to make an investment of $1.5 million a year here for the shingles vaccine, not just because it protects those individuals from the pain, but it protects our healthcare system from the strain of secondary intensive heart disease. This is preventative healthcare in action, Mr. Speaker. It's the story of what happens when you have a virus that has a long-term and potentially significant effect for years, decades after the initial infection. The science of chickenpox, shingles, and the associated increasing health risks is a perfect current example of something that we all understand of what a long-tail viral response is. A virus that has an incredibly long-lasting effect on a smaller and smaller number of people. And that is what the early data about COVID is telling us we need to expect. In fact, every pandemic has the same story. There are immediate impacts, a crisis. There are long-term syndromes and collections of associated adverse health outcomes that may not look anything like the original infection. We cannot ignore history and science for COVID and how long it will stay with us well past the time when the pandemic officially ends. Historians, economists, and health experts know all too well the breadth of ill health and disease that follows previous pandemics. Too many have clung stubbornly to the belief that COVID-19 is something from which a minority of people will die, and that most will bounce back quickly and intact with only their immune system updated. But the longer the pandemic drags on, Mr. Speaker, the harder it is to maintain that fiction, and the data is now there to tell us that that is in fact fiction. Now is the time to plan and pivot. Will we understand and pay attention to the lessons we have learned from chickenpox and shingles, or from HIV and AIDS, or from HPV and ovarian cancer? That infectious viruses can alter the body for a long period, forever, permanently, and create health impacts that we must be prepared for. With new diseases or new variations of old diseases, long-range effects take a long time to be understood. It took decades for researchers to prove a hunch that the infection with the Epstein-Barr virus is a trigger for multiple sclerosis, for example. Literally this year, in the last 12 months, that's been confirmed. Before Jonas Salk's polio vaccine was approved in 1955, polio epidemics regularly swept North America and Europe. My mum tells stories about growing up with the threat of polio and the joy and the relief when that vaccine became available, but also the sadness of knowing friends who got polio and never came home, whether they were in an iron lung or that they didn't survive. Everybody knew somebody who had been affected by polio. The polio vaccine was the savior, the relief that the problem had been solved by the collective will of the people and science and lots of money. But decades later, many polio survivors relapsed, and their condition did not get the same attention and support. Post-polio syndrome relegated thousands to a life of disability and poverty out of the public eye. Long COVID is the latest reminder that epidemics have long tails, biologically, but also psychologically, economically, and socially. Since the persistent effects of COVID-19 were recognized 6 months into the pandemic, up to 200 symptoms have been reported in 10 organ systems, including the skin, brain, heart, and gut. The recurring core symptoms, the most common symptoms, Mr. Speaker, include loss of mobility, lung abnormalities, persistent chronic fatigue, brain fog, and severe mental health problems. But it is clear that long COVID is a catch-all term for a huge range of post-viral syndromes, and we will be continually discovering and identifying new ones. And as a result, there is no simple test for it. Diagnosis currently is based on clinical symptoms, past infection with COVID-19, and the lack of any obvious alternative cause. Mr. Speaker, this is then an important point to reference the challenges that people may and will have proving that they have been infected with COVID-19. If they are unable to get a formal test via public health that is entered into the public health record, then their diagnosis may not formally exist. If they were infected with COVID early, before we had reliable testing, then they may not have a formal diagnosis or clarity that that is what happened to them. Or if they were asymptomatic and never realized that they did have COVID, they may not connect their later challenges and health challenges with an infection. There has been a tendency among health professionals and politicians to play down long COVID to begin with, and currently. But now, thanks in large part to the global online connections, long haulers have been able to develop, including healthcare workers, connections with each other. The internet has enabled people to find each other, to realize they're not alone, and to build support not only for each other, but for the recognition of the reality of long COVID, which has resulted not just in that support, but in actual research projects, significant research projects and grants, and even a few specialist clinics. Yet, long COVID and all of its implications continues to be overlooked by decision makers who still present the costs and benefits of COVID-19 containment in terms of data on cases, hospitalization, and death alone. This means that in many jurisdictions, a burden of future disability is being created that could have been prevented or at least reduced. Last week, Mr. Speaker, I tabled 2 significant peer-reviewed studies, including a meta-analysis of 29 global studies. We know that with the amount of information and research that's out there, it's absolutely critical that when we refer to data, we're referring to medically appropriate, peer-reviewed, and published studies. And a meta-analysis is an analysis of other studies. In this case, it was of 29 global studies encompassing 5 million participants. These studies make a clear definition of long COVID as post-acute sequelae of COVID-19, PASC, which was a condition as a result of a previous disease and the persistence of symptoms beyond 3 months after infection, including multi-organ damage. It provides us with the impact and the scope. And Mr. Speaker, the first time I looked at these, I thought that these were mistakes. I had to look at these numbers and look again and go and read the studies and be sure that I wasn't misunderstanding or misinterpreting the data. Long COVID is commonly defined within these papers as clearly as new or persistent symptoms at 4 or more weeks after the original infection. They are defined as syndromes or ailments that persist for at least 28 days after recovery, with additional data collected at 30 days, 60 days, 90 days, and 120 days. They identify that the prolonged symptoms are not distinct to older or younger age groups. This is not a syndrome that affects only those who are old. It affects everybody. And the findings of all of these analysis data with millions of records suggest that worldwide, long COVID comprises 43% of COVID-tested positive cases and 55% of hospitalized cases. 43% of those who have been tested positive for COVID will have long COVID symptoms. Most commonly reported symptoms are fatigue, shortness of breath, cardiovascular disease, and mental health problems. The dry conclusion statement in one report, Mr. Speaker, stated, "The health effects of COVID-19 appear to be prolonged and can exert marked stress on the healthcare system." I think, Mr. Speaker, that is the understatement of the century. The other study that I tabled, Mr. Speaker, looked specifically at cardiovascular outcomes 1 year after COVID-19. And this study demonstrated that the virus's impact is significant and long-lasting on the health of the heart and the circulatory systems. In an analysis of more than 11 million US veteran health records, it finds that the risk of 20 different heart and vessel illnesses was substantially increased in veterans who had COVID-19 1 year earlier compared to those who didn't. Heart attacks, stroke, ischemia, cardiac arrests, pulmonary embolisms, even people who were never hospitalized or got sick but were positive had higher illness than those who are not infected at all. So, Mr. Speaker, we are not talking about the percentage of people who ended up in hospital. We're talking about anybody who was infected with COVID. Anybody. In the post-COVID era, this is a quote, in the post-COVID era, COVID may become the highest risk for cardiovascular outcomes, greater than the well-documented risks such as smoking and obesity. That's a quote from Dr. Larissa Tereshchenko from the Cleveland Clinic, which is specializing in research on the effects of long COVID. She says, it is an equal opportunity offender. We found an increased risk of cardiovascular problems in old people, young people, people with pre-existing conditions, and the perfectly healthy. Mr. Speaker, their study included 11-year-olds who were having heart attacks. So how much does substantially increased actually mean? This study showed that veterans who had had COVID-19 had a 72% higher risk of heart failure after 12 months than those in the control group who did not test positive. Take a moment and process that. 72% increased risk of heart failure because you had COVID. Mr. Speaker, the authors of this study say that their findings suggest millions of COVID-19 survivors could suffer long-term consequences, straining health systems for years to come. Governments and health systems around the world should be prepared to deal with the likely significant contribution of the COVID-19 pandemic to a rise in the burden of cardiovascular diseases in particular, was this paper's conclusion. There are also, Mr. Speaker, initial studies that have not yet been further tested but are showing worrying concerns around the connection of COVID to diabetes. One study tracked over 47,000 people in England who had been admitted to hospital because of COVID in the first year of the pandemic. And these researchers followed those 47,000 people's health for up to 7 months after they were discharged and found 5% of those people went on to develop type 1 diabetes. They also showed that people who had been in hospital with coronavirus were 1.5 times more likely to be diagnosed with diabetes after they were discharged than people of the same age and background who had not been in hospital. Additionally, people who already have diabetes are at a higher risk of developing long COVID or COVID syndrome. I would remind the Speaker that 10% of Islanders live with diabetes. 10%. Mr. Speaker, we are 2 years in to COVID, and as I said at the beginning, we maybe want to be done with COVID, but COVID isn't done with us. Even if we make through this wave and we see the beginning of the end of the pandemic and the changes in the restrictions and guidelines that have made our lives so different for the last 2 years, we have to talk about what comes next. And no matter how much we want things to go back to be normal, one of the things that I think these studies show more clearly than anything else is that our healthcare system is not going to be able to go back to normal because people's health will not go back to normal. Mr. Speaker, in PEI, we are only reporting 16 deaths, and those deaths are tragic for the families that have experienced those. But we know that this data tells us that the deaths are not the indicator of the risk. We've had over 15,000 COVID infections, most of them in the last three months. But we have today over 15,000 positive COVID infections in PEI. That's 10% of our entire population. 70% of those people are at risk of some kind of heart challenge. 40% of those people are going to develop some form of long COVID, and they may not know that that's what's happened to them because they may not even know that there's a connection. But Mr. Speaker, we need to know. We cannot afford to wait for this to be a crisis for PEI. We already have a healthcare system in crisis, and we have no capacity for another. No one will benefit if we ignore the clear evidence, the science, and the data from around the world. We are not exempt from what happens everywhere else. That is why we are calling on this government to act now, to get ahead of the curve and let islanders know that you hear their worry. That starts by acknowledging the reality, the impact, and the scope of long COVID, listening to and working with experts from across the country and around the world and establishing a dedicated clinic for the diagnosis and coordinated support for islanders with long COVID. One that does not require a referral from a GP or a primary care provider, as 1 in 7 islanders don't have one. We have to remove the barriers and ensure there is no gatekeeping for those who may need support. Because, Mr. Speaker, long COVID is not going to discriminate. We have islanders of every age, every demographic, every social economic status who have been infected. COVID chooses no winners or losers, and our healthcare system must be ready. It must be ready now, and it must be ready with no barrier to service to help those who may not even know what's happening to them. The science tells us that this is true and real. We cannot continue in this House not to recognise that long COVID is a reality for islanders now and for the future. Mr. Speaker, I do have hope, despite how scary this is to speak about and to research and to bring forward. I do genuinely have hope that we can, because we have done so well in so many other spaces of bringing coordinated care in a time of great need. But everyone in this House knows how thin that line is between responding and reacting in a crisis. And our systems are strained, Mr. Speaker. So I am calling on government, please. This is not an issue we can afford to ignore, and it's one that I would really look forward to hearing that we will take with the urgency and seriousness that it deserves. Thank you for your time today, Mr. Speaker.